NHIF owes healthcare providers, government, faith-based and private, total about 30 billion. For us in the private sector, what we are owed is somewhere around 15 billion. We have been categorical that there should have been a reconciliation of pending bills so that each and every hospital can sign off with NHIF before NHIF closes. What we are concerned as providers is that somebody could switch off a switch one day and those claims become lost.
That is Dr. Brian Lishenga, who is from the Rural Private Health Association, Private Health Centers Association and Hospitals. And it's talking about why these centers, and it's not just him, there's also the faith-based organizations who seem reluctant to transition into the social health authority because of monies that are owed to these hospitals in terms of reimbursements from NHIF. When I spoke with the PS here earlier this week, the liabilities of NHIF are about 30 billion. I think for these two, it's about 15 to 20 billion or thereabouts. They're simply looking for a commitment. Now that NHIF is defunct, you know, in a manner of speaking, which is to say, yes, you owe us money. Can we then figure out what happens now under this new arrangement and how that goes? That is just, of course, one of the teething problems that we have seen with the transition from NHIF to the Social Health Authority, of which there are three that were so eloquently articulated here by one Sam Gituku last week. That there is SHIF, there is the primary health care, and there is the emergency and critical care. And Jamila, it is with, you know, the emergency, critical, and chronic care that we have seen the most complaints, particularly those who require dialysis.
Yes, those who require dialysis, Yvonne. And I think we've done stories almost every single day on the same, not because we're trying to hammer the point home, but it's because what is being seen in a lot of these hospitals. Dialysis patients require the service some twice, 3 times a week. And as we had mentioned last week, with NHIF, they were able to, by paying the 500 shillings a month that they were able to get services worth 9,500 shillings every time they went to the hospital, which NHIF was paying for. So they were able to continue getting their services. Yes, despite what is being promised in SHIF, that is not what is happening in hospitals. In fact, today, the Acting Social Health Authority Chief Executive Officer Elijah Washira directed all healthcare providers in the country to continue using the hospital's insurance claims management system to admit and discharge patients in the hospital as they work on the new provider portal, which means SHIF was not ready, probably, to go on when it did on 1st of October. Because you're being told to use what they already had, because patients are being turned away, Yvonne. They're being told that if you don't have cash, you can't come with your old NHIF card to come and be able to get the service. And then those who are asking what was the hurry in transitioning from NHIF to SHIF, this process could have been done gradually so that people do not undergo the inconveniences that they have. I was listening to 76-year-old James Kanyori, who's a dialysis patient in Nakuru, a story that was done by Marianne, and he was speaking bitterly about how he has nowhere to get the money. He's worried that he may even die if he does not get ile huduma. Anasema he's unwell, he's unable to survive.
We can hear from him.
Yeah. Do we have Number the 9. Sound bite of yes. Kanyori?
Yes, 9, yes.
Fanya hivi, uende, waambie watu yenyu, watoe pesa. 9,500. Na sasa mimi, sina mahali ya kutoa pesa. Mimi ni mzee miaka 76. Sina pesa. Sina mahali nikiomba.
Mzee Kanyori is one of several, Yvonne, and he's crying, a 76-year-old Mzee.
That's very difficult to watch.
Yeah. And he says he's been coming to the hospital and anapata huduma yake and he goes home. So
you know
he's being
what the irony is? For dialysis, SHIF has actually
it's gone up, the amount. It's 10,000.
10,650 per patient per session.
Yeah.
And yet, hospitals are turning them away because this money has not been
sent to the hospitals. They've not been paid. And I think we need to listen to Treasury CS John Badi talking about now we have challenges with funding this program.
I know that we have challenges with funding this program, but again, I think the government also took a deliberate effort. You know, some of these things, if you keep on putting them, procrastinating and putting them as stories, you'll never implement them. So at times it is better to roll out, face the challenges, resolve them as you move forward. The problem I see in this country is that we usually don't want any change. Let us also try some of these changes and see if they work. Of course, I'm not defending misgovernance or things like that, but on this, I also believe that we need to go the route of universal health care.
Jamila, I just have one thing to say.
Yeah.
He makes a very good theoretical point, but when you juxtapose that with what we've just heard from that 76-year-old gentleman, it's one thing to say, yes, we don't have the money, we need to start and roll out. But when that man is crying tears and saying he doesn't have the money at the age of 76 to go and do that, you know, you make these statements at hotels and fancy, you know, places in Nairobi, in the capital, but this has impact on real lives.
Yeah.
And so, you know, for me, it just strikes me as the two statements are just, you know, one person is, this has an impact on people. You know, this is not money that is about moving cups around, you know, in your cupboard. You're dealing with lives and you're dealing with health. So, yes, the government doesn't have infinite, you know, resources.
Yeah.
But then, aren't you ambitious to say with the emergency critical care and chronic that you intention for it to have 75 billion, but can only allocate 2 billion for primary health care? That's for up to level, what, 2? You intended for it to have level 3. You intended for it to have 50 billion, but you can only allocate 4. You know, clearly, there was no money, and like you were saying, you know, why would you then start this, promise this, and then not knowing full well that you do not have the funds for it? So he can say all he wants to say, but tell that to Mzee Kanori.
Exactly, and when he says that people don't like change, we didn't say we didn't want change.
Tell that to Mr. Kanori.
Make it gradual in such a way that there is almost seamless transition, because
Right.
as you said, this is human life you're talking about. Yeah. I worry us going back to where we were 10, 11, 12 years ago, and there was only one dialysis machine, which was at Kenyatta National Hospital. And I think for 3 sessions of us, it was about 30,000 shillings. And people would lie outside the corridors there waiting, because tani yako ikipitwa na uko hapo, unaenda mwisho wa line tena, uanze kufikiria tena how you'll get into the line to be able to have dialysis done. On top of that, people did not have the 30,000 shillings. So when this 9,500 NHIF deal came in, it saved people's lives. My worry is that we'll go back there. And finally, as Gituku takes over, this is dialysis patients. We have hypertension patients who have only 3,000 shillings a year. That is just medication, I think. We have not talked about the checkups. We're not looking at diabetes patients, 4,300 per person per year in a family. We've talked about all those things that diabetes does to you, from strokes to amputation to kidney failure to blindness. You're supposed to have regular checkups for you to be able to avoid all those things, but there's no money for this. This should have been well thought out before being rolled out.
Right, and to add to that, you see, it's not like these patients asking for free money.
Yeah.
They have been contributing.
Yeah.
They're up-to-date, paid-up customers under the National Hospital Insurance Fund. And remember, like the Principal Secretary told you here in studio, that it extends to 22nd of November 2024, because that's when this law turns 1 year since being gazetted as the effective date. And therefore, it is quite unfortunate that this transition was done and it was not clear on what hospitals are supposed to be doing, what patients are supposed to be doing, that you have to get to an extent. And you've seen a lot of stories even on social media platforms that you find even the hospital indicating to you that is it NHIF or is it SHA now, is saying that they're only going to pay up to 2,000 shillings, or they're about just over 2,000 shillings. So this could have been done differently, knowing too well that there are people who really depend on that card to access service. They have scheduled appointments. what was so difficult, even getting in touch with these hospitals and ask them, based on the current existing packages, because the law says that the existing packages are going to run up until expiry of that program. Remember, there are some, what is the name they are called? The specialized programs under NHIF, the packages that exist there. And so they usually run per year. So if there's one that you run up until, say, was extended from June 2024, it will run up until June 2025. It should continue to exist up until exactly up until it expires. So what was so difficult for the Social Health Authority and the NHIF officials, because they're still in office anyway, to just do a survey within the various clients they have, the hospitals themselves, and ask, how many of you are dealing with how many patients under certain packages, and what resources would you require as you transition this program, so that you also do some financial planning to an extent that even if you're saying that 30 billion shillings are owed to service providers by the NHIF, and there's a challenge of cash flow, which again, like we said last week, is a problem that has been orchestrated by the government itself. You're talking about the county governments that don't remit resources. You're talking about the national governments that deduct contributions from employees, deductions for NSSF, deductions for NHIF and other, even SACCO emoluments, SACCO remittances, but they don't remit these resources. So it could have been done differently by that proper planning. At the same time, this week, Yvonne and Jamila, the National Assembly Committee on Health gave, is it what we call a clean bill of health? Yes. To the ministry in as far as the 104 billion shilling worth of a project that is called Integrated Healthcare Information Technology System. And this was the culmination of meetings that have been held by the committee with its stakeholders, including one that was held in Mombasa. I think it was over the weekend. And the committee members had an opportunity to be convinced of how great things were being done by the Ministry of Health, of course, together with its partners under the consortium of Safaricom, Apero, and Convergence Network Solutions. So it was quite a great move for the Ministry of Health to have that okaying of this project. But it doesn't end here, because there has to be an assessment of value for money. Remember that conversation again you're having with the Principal Secretary and asking about what it means for the next 10 years, where deductions will have to be made and remitted to this consortium, some 10 billion shillings every other month, and it's to be paid in monthly installments. That will have an implication on the fund itself, that is the Social Health Insurance Fund, because remember, as she says, the government has not allocated resources, not even cent. It has not allocated resources for these other funds, the Primary Healthcare Fund and the Emergency Critical and Chronic Illness Fund. So that being okayed by the the National Assembly Health Committee, it does not mean that that's the end of the story. There's so much work that is to be done in the coming days, but I think for now the most important thing is what is happening. This is the week that we've seen migration of, is it over 9 million NHIF members or contributors moved now to the new system, the Social Health Authority. Again, you ask, why did it have to take all this, knowing too well that the conversation has been that you have to apply to register. So people have been struggling with the website, but then now this communication comes to your mobile phone and you're told that you've been transferred. You need to update your details. Exactly.
There's this one thing, last thing I will say on this. The government's tendency to issue pronouncements and instructions to these institutions, hospitals, to not turn away patients. It sounds very familiar, doesn't it, with the university funding model, where they told universities, don't turn anybody away. Okay, are they having conversations with them where not turning away means what? We're giving this guarantee. Right? That if you give a service, they're not going to take a pronouncement or a seeming instruction from government through the media. There has to be some level of conversation, sitting down, maybe MOUs that are signed, some sort of agreements, because look, the faith-based organizations are saying they're worried about the transition because when there's been a system change, when they've experienced that in the past, claims that were in process got lost. Right. So my question is, when you issue these statements out here in the media, is that how you are working collaboratively with these health-based, health institutions towards providing healthcare? They incur expenses to provide that healthcare, and remember, they provide the service in advance, waiting for reimbursement. They're owed over 15 billion to date. What assurances are you giving them? In writing. Not through the media and saying, we have asked them not to turn away. As who? These are people who run businesses. And who have overheads, who have to pay their healthcare workers, who have to buy medical equipment, who have to buy medicine and provide this service in advance before getting reimbursed by the government that to date has owed them billions of shillings. You cannot be issuing statements in public and saying, you know, don't turn people away.
In fact, I was going to say, you see, at the university level, there are certain courses that are more theoretical than practical.
Right. Yeah.
So all you need is a lecture.
Yeah.
The lecturer is
there.
there.
Are others.
The laptop is there. The project is there. Teach. So when you tell them money will come, they can teach. But the practical lessons that require supplies, laboratory supplies, how do you teach? When you come to the hospital, like you're saying, pharmaceutical supplies are required and they have to be procured. And procurement happens, I mean, they have to measure, do you want to do it quarterly, do you want to do it half yearly, or do you want to do it annually? Of course, based on the expiry of some of these commodities. So for commodity security, you need resources. So you're telling them to treat, don't turn them away, but where the resources to make sure that the commodity security is well taken care of. So much work to be done.
So much work to be done.
A lot to look out for.
That's right.
Okay, I think we can now say